Well, good morning, everyone, and welcome to Internal Medicine Grand Rounds. That's a wonderful day that we actually get to have the Jeffrey P. Callen lecture. And of course, to introduce our lecturer, Dr. Stratman, I'm going to introduce Dr. Callen to do the introduction, but just wanted to say thank you for all of your decades of service and leadership here, Dr. Callen. It's wonderful that you've arranged so many innovative things in dermatology and on the educational side. And this is a wonderful opportunity to express appreciation for you. So let's give Dr. Callen a great introduction to the show. Thank you.
Okay, thanks, Kim. It gives me a great pleasure to introduce a good friend of mine in dermatology. Erik reminded me last night that we met almost, about 22 years ago, something like that, after he completed his residency. And he was, I think initially, he was thrown into the position of being the assistant program director at Marshfield Clinic. And so I'm probably 25 years a senior. But one of the good things about being senior is when you've accomplished, at that point, I'd been program director here for a number of years. I think at that point, I'd probably been program director here for about 20 years, which now Erik was the program director where he is for, 20 plus years, and then became the chair of their department. But one of the things is that you can recognize talent in someone, and he was talented as a educator at that time and planning education, and he has made a career out of his abilities in education, and I was able to be I think a mentor to him. And then he has been a mentor to very many people, including Dr. Schott, who's our program director here now. I think that's the greatest compliment that a mentor can have, is that his mentee goes on to mentor other people. And that's what's happened with Erik. Erik is at Marshfield Clinic. He's a clinical professor of dermatology at the University of Wisconsin. He's the head of the department. He trained at Missouri, which is where he's originally from, in undergrad and medical school, and then went up to Wisconsin to do a residency, which was a combined residency at that time between Marshfield and the University of Wisconsin. And then he stayed on at Marshfield and has been there ever since. He's fitting to an educator is that he's also a coach. And so he coaches football. What you name the sport, I think he coaches it, And some of the time he can't go to meetings because he's a coach. And now he's just joined many of us in the room who have grandchildren, and he's had his first grandchild. He has 4 kids. 2 of them, one of them is about to graduate from medical school at University of Wisconsin. Second one's in her medical school at University of Wisconsin. You're going to hear a theme here. And then his son, who's the third one, is in the dental school at University of Wisconsin. And his last kid is at University of Wisconsin as an undergrad. So, he was an empty nester for about a period of about 3 months until his oldest daughter had her baby. And when she had the baby, he and his wife have now become, they have a purpose again in life, raising a new generation. So without further ado, let me introduce you to, let me have Erik Stratman take over. He's going to talk about infections in dermatology.
Well, thank you, Jeff, and thank you, Dr. Williams, for the invitation, and everybody that's here and online. I appreciate it. So I don't have any relevant financial conflicts to disclose. I am an up-to-date associate editor or section editor, and I'm not going to be referencing anything that I'm in charge of there, but I will be referencing some up-to-date in some of the things that we're going to talk about. I like to talk through cases and do a little bit of learning through the cases that have taught me a lot of things. And some of the key messages that I'd like, and that's really what we're going to be covering today. When you think about the dermatologist lens of infection, you have a very big high level view, and that is things like aerobic bacterial infections. Very commonly, we're talking about folliculitis and impetigo. It's fungal, with the superficial infections, in particular a dermatophyte infection and candidiasis and things like that, and viral infections commonly with herpes viruses and your papilloma viruses. But I think that a lot of us, we certainly don't just end there. We have a whole other kind of spectrum of disease that the medical dermatologist is much more in tune to, atypical mycobacterial infections in particular, some oddball bacterial infections with rickettsial disease, where I'm at, a lot of spirochetal disease with Lyme, and then various parasitic diseases as well. And so the soup to nuts of infectious skin disease, I think, is something that I've always enjoyed. And the reason, very shortly after I started, this was the most famous picture that I ever took. And this was the very first introduction in my world in the mysterious infectious disease. And this was my patient who had a febrile illness. This was about a week into her illness. This girl had been to a Mother's Day animal exchange, which in central Wisconsin, believe it or not, is not that unusual. It's not so much exotic animals anymore, but at the time it was. And they had picked up a couple of prairie dogs in this animal exchange, and one got very, very sick and died on very shortly after it went home, and the other one was getting sick and actually bit the child on the finger here. And this lesion developed, and the child was starting to get sick. And then shortly after that bite, that prairie dog died. Well, this child presents to this was in Dorchester, Wisconsin, which is about 20 miles up the road from Marshfield. And they were in our children's hospital, and we were consulted. And you know, listening to this story, it's so bizarre. It's like, I mean, you know, and you know, like all of us would do, you're getting on PubMed and you're like, well, what infections do prairie dogs cause? And there was just nothing really coming up. I mean, they do cause, you know, disease, but nothing. Because when I looked at this, I said, you know, this does look familiar to me. But in addition to this, I'm just going to go forward. She also had some other like pustulovesicular lesions that were popping out. And so to me, this is like, well, geez, you know, there's a primary inoculation of something, and then it's starting to go hematogenous and making this kid sick. But when I look at this first lesion, I said, well, I don't know what prairie dogs have here. But I do know that I've seen something that looks very similar to this. And what I've seen in central Wisconsin that looks very similar to this is ORF. And ORF is a pox virus, and a pox virus that we see very infrequently in dermatology, not because it's not happening. It's because, ORF is a pox virus that happens in sheep farmers predominantly. But they never come in for it because they know what it is, and they know it's self-limited, and they know it's going to go away in a while. Who we see ORF in my world are the hobby farmers that don't know what this is, and that's who we see. But in looking at the morphology, and the morphology was really what was important to me, is this looks like something unusual and viral. And that's what got us launched into further investigation. And we did some additional studies, and this is just going through what the various pox viruses are. This is like what's churning in my brain. Like, okay, well, what kind, if we say it's a prairie dog pox virus, well, what is out there? There was nothing out there. Okay, nothing out there. And in that, what most people don't know about this story is that it wasn't actually that index patient where the answer was found. It was in her mother. Her mother, who had been taking care of this child, but also had been taking care of, like, you know, the dead animals as they were needing to be disposed of. She actually had a cat scratch on the back of her hand, and a similar appearing morphology occurred in that cat scratch. And it was the biopsy of her lesion that actually gave us the answer. And it wasn't going to be enough just to say, well, let's do, at the time we were doing direct fluorescent antibody tests and today we would do PCR for different kinds of herpes viruses, HSV or VZV. But in fact, what we did here, we said, I don't think this is either one of those things. So let's just do a pure viral culture and see in the viral culture medium what happens. And what we ended up with is we started to grow something. And what we started to grow, we then took a look at under electron microscopy and found this pox virus entity that was starting to grow. Well, there were some negative stains that were done, or negative scans that were done on electron microscopy that became very concerning because it was like, well, we only see this in smallpox, in recent times. And so that, of course, gets all alarm bells going. So we sent this to the CDC, and the CDC does special stains and in fact does confirm that it's an orthopox stain. So, okay, well, if we're in the orthopox in the upper left there, well, you've got smallpox, monkeypox, cowpox. That's basically what you're looking at. And well, there was no reports of the cowpox in the prairie dog population. A state epidemiologist gets involved, and this was like as close to CSI. This was before CSI even existed, but it was really cool to kind of be a part of the epidemiological work on this. But they did a tracing, and this guy on the bottom right is like the Bloody Mary of this disease. And what this guy did was he is the exotic animal distributor. And it's a pretty violent thing, as it turns out, how they extract prairie dogs for this thing, but they suck them up in vacuums in their little holes in South Dakota. And they had a big cage full of prairie dogs, and in his vehicle, this van that was going all over to do these exotic animal, trade outs and whatnot. But he had that cage right next to the cage of a Gambian giant rat. And that was from Africa, and that giant Gambian rat was sick. And they're all rodents. So prairie dog's a rodent, the Gambian rat's a rodent, and they were, swapping germs. And the Gambian rat infected a whole bunch of these prairie dogs. And so the CDC was a good ally in this because they're the only ones that would, at the time, would be able to say this is monkeypox. And this was monkeypox. This was just the beginning of, because these sick prairie dogs were distributed all over the upper Midwest. And these were the cases, the 37 case outbreak. Now, the clinical presentation at the time, many of these patients, they all had prairie dog exposures. There was no absolute human to human spread. Although I would say the mother probably had a lot more likelihood of being human to human spread from the sick child, taking care of her and then dumping the dead prairie dogs. But she did contact, so you couldn't say it wasn't, or it definitely was human to human in that case. But a lot of lymphadenopathy was a big part of this as well. This is the index child and me with a lot more hair. And, but this was the timeline of monkeypox. I apologize because I haven't quite grabbed the mpox yet. I will now say it from this point on, but the story to this point was monkeypox. And it's called monkeypox because it was originally identified in monkeys. And then in 1970 was the first reported case in the Congo of it in humans where it was identified. Now, what I don't have on here is 1972 would be the last time that our population of in the US were given the smallpox vaccine standardly in childhood. I'm right past the cutoff line, so I don't have the little scar. But people in my class, half of us had it, half of us didn't. So I was born in 1972. 1980 was when the CDC declared, or the World Health Organization declared that the smallpox had been eradicated from the wild. So so now we're in 2003. That's this was the time when this happened. This was literally 45 days before I met Dr. Callen for the first time. We had him up for our grand rounds just shortly after this happened. So you never know what you're going to get out of Grand Rounds. Keep inviting those speakers. That's good relationships can happen. But then we flash forward to just a couple of years ago, and I'm sure that a lot of you were involved in cases of that happened in the Mpox outbreak of 2022. And why did this happen? And some of this was driven by that fact that now the people that are young and getting the outbreak at that time, we had kind of this waning smallpox immunity. Because all those people that got the standard vaccination are now older and whatnot. There was a COVID-19 relaxation of being pent up. Resumption of international travel became a bigger deal, and then large gatherings, sexual interactions in something that I had never heard of until this outbreak, and that's a circuit party. And this is what was a big part of the spread of this. They're large dance parties that go on for 2 or 3 days. And a lot of the initial outbreak was traced back through epidemiological studies to 2 very large circuit parties in Spain and Belgium. Over 65% were exposed with some kind of sexual contact during these circuit parties. Now, they were very different demographically, like how was this presenting? 98% were men who had sex with men, 75% were white. And you can see that, you know, although there were some of the signs that were similar with some lymphadenopathy and fever and that sort of thing, much more mucosal in the outbreaks and a lot more pain associated with those mucosal outbreaks. Now, the where you were having your problems had to do with the sites of inoculation. So the mucositis, the proctitis, those were big areas of involvement. And then there were, you know, some lesions that you would see. And when we look, you know, this is not terribly different morphologically. And so today I'm going to keep going back to morphology because I think morphology is the most important of the things to pay attention to. But what we see here is outbreaks, and when it gets on a mucosal surface, you know, of course, papular vesicles don't last long, and you're much more likely to have more of an aphthosis or an aphthay or erosion based outbreak. And you can imagine why that would be painful. And in addition to this, you know, what we were seeing was, this is a global map, and the blue circles are where we normally expect to see monkeypox cases. And the orange circles are where we don't expect to see it, but we're seeing it. And so you can see, like, there was quite the global outbreak that was occurring, over 92,000 confirmed cases, and only, you know, basically 2,000 of those were in places we normally see it. So it was definitely out of the box of where we usually see these outbreaks. When we identified the monkeypox in the child, that was the first time that monkeypox had been seen in the Western Hemisphere. And so now we were seeing huge numbers. And I took a look at the national data here, and you guys did have 110 cases that were reported as of a month and a half ago. I don't know if you've had any more since then, but in this case, there was also in the US 56 mortalities from that, usually from like perforated rectum and things like that that were causing problems, and septicemia and things like that. A couple of other things about that outbreak: 52% HIV positive, and then sexually transmitted infections in almost a third who were tested. So that's not everybody, because not everybody was tested, but of those tested, about a third. And then I just mentioned this briefly, but a whole lot of different kinds of complications that came with the second one that you just didn't see with that 2003 outbreak. Now, testing, there are certainly good tests for Mpox. I'm not sure, did you guys manage any Mpox outbreaks while you were here? Initially, it was a kind of a scramble, like how do we test, how do we treat, viral testing available, PCR. We were, given the instructions of 2 swabs, vigorously rubbing, and not to add the viral transport media, just send it down, and to sort of anytime you thought you were dealing with that. And it's actually very interesting, at least in 2003, when we were having the mpox problems in our prairie dog situation, like everything that came into the ER for like a month was, I think this might be monkeypox. It's like, oh no, that's actually just hand eczema or whatever. So, but everything was that. So how do you treat it today? Supportive is important, whichever mucosal surface you're dealing with. Give them some supportive care there, but also some antivirals as a treatment of choice, the ticoviramat, and pretty well tolerated. For severe diseases, the people who are immunocompromised, people who have areas like eye involvement or other areas concerning for strictures like urethras and things like that, that would be a bigger problem. Vaccination strategies, given the Jynneos vaccine, 2 doses, 4 weeks apart, pretty standard. Usually you want to do that within 4 days of exposure when possible, though if it's a high-risk exposure, you can consider it up to 14 days afterwards. This is the team that was the 2003, and this is one of my points that I just want to make, because a lot of people that are here and that are listening online, you're not going to be in academic medicine for your career. I mean, hope that many of you are, but many of you aren't. Most of you probably aren't. But that doesn't mean that you can't think academically, and this was one of my favorite quotes, and it's by Ed Blau, who is attributed to Blau syndrome, one of the sarcoid disease. He was a Marshfield clinic, a really scary attending, by the way. But this is something that he says, that everything hasn't been found, and you wonder how all these things end up in textbooks. It's because somebody was curious and somebody pushed ahead, and you don't have to be at a big university to think like that, So be curious, keep looking. And throughout the rest of this talk, when I get to a red slide, that's one of my key points, and that is, here we have 2 different, 20 years apart, 2 different outbreaks, very, very different demographic. And so just remember, when you're talking about infectious disease, the nature of the exposure or the vector can matter how that disease presents. So don't be rigid in your defining criteria, like, oh, well, this can't be monkeypox, even though it looks like monkeypox. Can't be monkeypox because there's no prairie dogs involved. Well, that's not going to work. Or this person hasn't traveled to Western Africa. It can't be monkeypox, So that's one of the things. Appreciate the morphology and then remain curious. So I'm going to move on then to chronic spider bite with hand pain. So I get a consult, a call from orthopedic surgery. We're considering amputating the digit and part of this 65-year-old man's hand for osteonecrosis from a brown recluse spider bite. But we would like this lesion evaluated by you first. Okay. So I don't need to see what they have first, because the first thing I'm going to talk about is the brown recluse spider bite. I don't know where in medical training that necrotic arachnidism became such a widespread phenomenon. But I have met so many urgent care and emergency room doctors that believe anything on the skin that isn't rashy was caused by a spider. I live in the Star, where the Star is here in central Wisconsin. And there are no necrotic arachnidism spiders that live in my area, and I will put an asterisk to that yet, because later we'll talk a little bit about what global warming is doing to the migration. But I see that in Kentucky, at least, you do perhaps have some necrotic arachnidism spiders. You can see the brown recluse or fiddleback spider on the upper right with that fiddle, upside down fiddle on its back. as one of its distinguishing features, and showing you about the size of it is in a quarter. But I knew that this was not likely brown recluse spider bite in central Wisconsin unless this person came or migrated from somewhere further south. But this was his hand. And we do an e-consult service. Do you guys have like a triage electronic consultation at all where people are unofficially, right? So I would say this, so one of my advice is get it official, because you can charge provider consultation for it. So so this was the guy's story. 65-year-old heavy equipment operator, northern Wisconsin, with a progressive 9-month history of this hand problem. He had presumed that it was a spider bite that had formed, but he never saw a spider. He had not traveled outside of the state of Wisconsin. He was a lifelong resident. Initial x-rays like 5 months ago, 7 months ago, had shown soft tissue swelling, and that was pretty much it. He had failed multiple urgent care antibiotic courses with ceftriaxone, trimethoprim, sulfamethoxazole, doxycycline, and hand culture 7 months prior had grown nothing. It was treated with incision and drainage around that time, but the hand progressively worsened. Okay. Now, here's another one of my key points. When somebody tells you or documents that cultures were negative, I would just request that you dig into that a little bit. Like, what does that mean exactly? What kind of cultures were drawn or taken or submitted? And this is one of my mentors' old quotes, quoting an 80s Cold War thing, but trust but verify. And I think that's important when you're talking about microbiology, things in medicine. So to me, what is the full spectrum cultures is aerobic, fungal, and mycobacteria. If somebody says that, if my resident said cultures are negative or tissue cultures are negative, that's what I'm expecting to be the answer. What this man had were aerobic and anaerobic. Now in the skin, I don't have a lot of utility for anaerobic. I almost never have in my entire life ordered an anaerobic culture. I'm not saying there's not a reason to get it. It's usually some kind of bowel, infection or something like that. But most of our stuff is touching the air, so it's probably not going to be anaerobic. But trust but verify it. So spider bite and hand pain, the past medical history, not terribly revealing. Some chronic opioid use, some lumbar back problems that were chronic. Doesn't drink alcohol, but does smoke a little bit. On a fair number of medicines that are pain related. Not much else to add. But when we get to the review of systems, he's been a little bit more tired. He had COVID-19 in 2021, had a cough, kind of dragged out. The cough seems to kind of come and go, gets worse with diesel fumes in his tractor that he drives. But he, had a little bit of a flare of the cough in 2022. No real GU complaints besides erectile dysfunction. And he's had this chronic low back pain for a couple of decades. So this is when we saw him in person. If you kind of compress the area, gets a lot of little dots of pus start to kind of poke out. And to me, the one thing that I would say, just if you are in a necrotic arachnidism location, what I appreciate about his first and second picture here, it's a little bit more verrucous. It's not like death in the middle and these like this evolving death. It's a little bit different than that, and not really a centrally necrotic thing. This is an inflammatory plaque that's a little bit verrucous. Now, his labs at the time didn't really have elevated anything. Everything looked pretty good. Now, this was his hand x-ray where I was telling you it was some soft tissue swelling. At the time that he was sent to me, this was his x-ray. Now, I'm a dermatologist. I don't deal with a lot of x-rays in my life. But even I can see that there is something very, very wrong about that hand. And over the course of time, this bone has eroded, its finger has shrunken down. This is a pretty destructive thing, what's happening in this bone of the metacarpal. Now, as I told you, when you press down on the hand, there was pus. Now, pus to a dermatologist with a microscope in the office is like the mother's milk, right? And so it's we take our glass slide and we touch that and we do our KOH. And this is what was on the KOH. Okay. Who wants to take a guess at what this is? Blasto is what I was thinking as well. We have yeast. These are yeast that are budding, and they're what we would consider broad-based budding as well. Now, chest X-ray, which was then done, was compared to an earlier one, and compared to the early one, there was some right apical pleural thickening, mild atelectasis consolidation, mid-lung patchy alveolar and interstitial densities. However, we do the blastomyces antigen urine test, which we love because it's a lot quicker than waiting 4 weeks for a culture, and it's negative. So what does that mean? Was I looking at an air bubble? Well, we've actually done that study, and the study that looks at, well, what is the sensitivity of this urine blasto antigen? And this is from our experience at the Marshfield Clinic patient population of blasto, because we have a ton of blasto where I come from. And the test would report out, oh, it's 95%, you know, but it's not actually in real world usage. And it really depends on what is the nature of the infection. Is it pulmonary? You're getting bronchial, sputum that's coming out. Is it disseminated, hematogenous? Is it primary, cutaneous? What is it? But it's a wide variety. So it's not a perfect test, as no test is perfect. Biopsy showed us this, microabscesses, yeast forms, the GMS staining was here. The GMS stains the fungal organisms black, and you can see very, very good for blastomycosis. So our diagnosis was North American blastomycosis. We were able to say, hold on the hand surgery. There's not a need to amputate, certainly. I'm not going to say there's not going to be a reason. You know, it's osteomyelitis basically that the guy's got with blastomycosis, so it may be necessary. But they were happy to say, well, let's see what the itraconazole therapy will do for this hand. This was our regimen. There are many ways to treat blastomycosis, but ours is, we do a lot of itraconazole where I'm at, and it seems to work very well. It doesn't necessarily, we monitor it, but it's not a real dirty drug in my opinion. Certainly not like Ampho-B would be. The things that I want to just point out, is in this case, was this primary cutaneous? Because this guy was like a dirty worker, and it lives in the soil. He's dealing with scratches and whatever, and in his heavy machine operating lumberyard kind of stuff that he does. Or was this something that was disseminated? And I think that with the pulmonary change and that kind of story, well, it may very well, because he's also kicking up a lot of dust and breathing in a lot of stuff. So it's probably your regular old blastomycosis with a little pulmonary touch and a little bit of hematogenous dissemination. But the things to remember when you're looking at it, bone is a pretty significant other organ system that gets involved with this, and I also ask about GU symptoms in men, because the GU is something that we see some epididymitis, orchitis, not uncommon where I'm at. This is probably the worst bone involvement that I've seen in recent times. I've seen it before, but not in a while. And here's something when I was a resident, actually. in your shoes that I took a picture of. And remember this, blastomycosis affecting the skin may cause pseudocarcinomatous hyperplasia. Okay, so it can look a lot like a squamous cell carcinoma. This was a plastic surgeon that had looked at a finger lesion in a patient and said, oh, this is classic squamous cell carcinoma. This is, unsalvageable, and chopped off a finger. Well, as it turns out, the finger was just pseudocarcinomatous hyperplasia with blastomycosis, and would have been cured with 6 months of a pill. So you want to make sure that you remember, like, superficial biopsies can be a little bit confusing. Make sure that you don't just automatically go for the amputation. This is the guy after a couple of months of the itraconazole. We're just at the beginning stage. He actually is a guy that does not like to come down to the doctor. So he sends us some photos. We do a little telehealth at home with his friend, kind of running the cameras and stuff. So it's been real interesting. But this is North American blastomycosis. So again, Kentucky is a part of this. You guys see a little bit of blastomycosis. So that's good. Brings me to the next key point. It's helpful to know the geographic distribution of infectious disease. Okay. Or is it? These are 3 different photos of cases that we have seen in the last 2 years in Marshfield. And each one of them represents coccidioidomycosis. Okay, now let's take a look at the map of coccidio, right? This is like your valley fever. This is your southwest, kick up the dust as you're leaving the car park or whatever. And again, the star is where I'm at, right? So the important point that I want to make here is, it's not just say, well, he's from here, therefore it can't be that. Keep your differential open, explore the travel or migration of your patients as well, because in all those cases, they were originally spending time in that area and had migrated to our area. Next, fever and mosquito bites. Okay, this is urgent care. Woman with a new skin lesion. She thinks it was a backyard mosquito bite. She had some recent fever, some drenching sweats, and myalgias. We think it might be a spider. What should we tell her to be putting on these bites? Well, I took a look at this. I'm like, okay, I've seen a lot of mosquito bites. I've seen a lot of spider bites, and I've seen a lot of things. This doesn't look familiar to me. So let's take a look at her. I'm not just going to answer this e-consult and leave it be. So had her come in that day because it did look curious. This is a 54-year-old woman. She had a recent 8-day trip to South Africa. Well, that would have been nice enough, right? It's like that was a big part I didn't ask about for a big game hunting trip. On her long airplane ride home, she became very febrile and felt sick and fatigued and had myalgias, diaphoresis. The first day back home, she's recovering in her backyard and noticed a couple of these lesions, and that's why she thought it was mosquito bites, because she just noticed them as she was reclining in the backyard. And in Wisconsin, that's our state bird, is the mosquito, so it's not uncommon to get bit pretty handedly. She had noticed that over the past few days, all of the skin lesions were worsening. She was still sick, but not as sick. She was like on the back end of that condition. She did not have any history herself of having ticks on her, but many in her party did. So there was some ticks while in Africa in the bush that they had noticed. She had only been using triple antibiotics. She had a few kidney issues in her past, but a pretty healthy lady otherwise. This was the lesion on her thigh. And when I look at this one, this was the other big lesion that she had. The other one I'll show you in a second, but very kind of necrotic center, a widespread erythema around it. And this was the other one in the popliteal fossa, where it shows also like some impending necrosis there. Now, when I looked at this spot, there was something that came to my mind in that day, in that moment, a couple of lesions like that. I was actually thinking a little bit about rickettsial pox, and rickettsial pox is something that we see in the US, mostly in big cities in the Northeast. I'm not sure if you see much of that here. We don't see this, but also with this, like, single or couple of lesions, and that's from the mite of the house mouse is where that's coming from. I wasn't familiar with African tick-borne disease at this time. And so this is what you do, right? So if you have a couple of things, and maybe if you're using Visual DX, that helps you diagnostically. For me, I go to PubMed, and I'm like just searching, okay, and I put in what I know, tick, Africa, necrotic skin lesion, right? And all of a sudden up comes a few different articles about African tick bite fever, and that gets you then reading about, well, what is African tick bite fever? Because I should know more. I don't know it, but let's investigate it further. Now, in this, what I find is, gosh, everything about this really fits. You'd been right to the area that this is endemic. It's a rickettsial disease. I thought it looked like rickettsial pox. I think this all fits. And so, of course, there's not some simple test you can say, well, show me, is it rickettsial disease? And so, this is the other point I want to make. Like we have a great government that has, resources for weird things, and don't be afraid to, get your state health department involved when you think you got something weird and they can help you. And this was our conversation with the rickettsial folks. And our biopsy, even though she had no history of ticks on her, wouldn't you know it, right at the top of the center of this biopsy is a little mouth part. Because remember, that's the best thing about ticks. They can't let go of you. They once they're in, they harpoon you, and that's it. They dissolve their mouth part, and that's how they fall off. They don't let go. And so you're going to find a mouth part in there if it's there. And that indeed is what we see here. So indeed, she had been bit by a tick with a vasculitis that occurs, a necrotic vasculitis that occurs with this condition. So the CDC then, they've got all the stains and they've got all the different ways of identifying their PCR primers and such. And so it was very helpful in that way. And everything you see here that's a red color, that is a rickettsial positive stain in the various sections of what we sent to them. And they were very, very helpful and very, eager to help and get something weird. And so this was African tick bite fever with our PCR, and they actually ended up identifying. We sent them some fresh tissue, and that worked very well. Rule of thumb: if you ever have a tick-borne disease, you're probably never wrong giving them doxycycline, even if you don't know what it is quite yet. I think you would cover about 95% of every disease that happens in a tick-borne rash, but she did very, very well. Now, case 3B is 1 week later. In comes another guy. Okay, this is a young, healthy guy, 26-year-old guy, returned from South Africa on an exotic hunting trip, and this is him. Okay, so in 1 week, a disease I've never seen, right? In walks another guy. And so here you can see a little bit more lymphangitic streaking, which is pretty interesting. And that's something that we have here, and other necrotic lesions as well. And this is kind of my walks like a duck, quacks like a duck. Do we really need to spend $1 million on this duck? And I would say no. And that as an academic at heart, it's hard for me to say no, but I would say we just move forward and treat this fella. So it's caused by Rickettsia africae. It's endemic in Africa and actually in the Eastern Caribbean, which I did not know until preparing this talk. I knew it was in Africa, but not in the Caribbean. And it is very much like that rickettsial pox kind of look in the skin lesions that are reported. It can also cause a more widespread rash that's a little more evanescent, macules and papules, but it's those solitary lesions. You can have neuropathy and myocarditis with. So the message here, you know, the world has become a much smaller place with the international travel and just the interest of people doing that. Think about travel and the infections that occur, not just where they live, but where they have been, and expand your differential. And I guess the other important point I've already said, which is, you know, don't be afraid to be curious and say, this is something weird, right? This is something weird. I'm not exactly sure. I don't have the expertise in this moment, but I'm going to find out. I'm going to be a resourceful information gatherer. And that is also even a resourceful problem solver by, you know, connecting to people at the CDC and the state health department and whatnot. Then I'm going to finish with this case, and this is a resistant cellulitis with progressive malaise. So this is a 77-year-old guy, was referred to us from the urgent care, or actually the emergency department, for failing course for resistant cellulitis. He was having a red swollen calf, and he had undergone some antibiotics. He was an immunosuppressed guy because he had rheumatoid arthritis, on multi-drug immunosuppressive therapy, which I'll show you in a minute. This had started as bumps after according to the patient, after walking in the tall grass that he thought were bug bites. The inflammation expanded on his left calf. He had had a course of cephalexin, and it was mildly better, but not clearing. And so they just wanted to know, is this something, because we need to get it clear, because the guy's got ulnar neuropathy that we need to do a release. And so we want to move forward with his orthopedic surgery, but we're not going to do that with this cellulitis hanging out on his calf. So his immunosuppressives, you know, he was on hydroxychloroquine, methotrexate, prednisone 5 milligrams daily. And I guess I said hydroxychloroquine twice, sorry, but the rest of his stuff, bone protection, et cetera. This guy was a lifelong chemist, or not a lifelong, but he worked as a paper mill chemist. Paper mills are big in Wisconsin. He was a chemist for one, so an intelligent guy, and had lived in northern Wisconsin this whole time. He was an avid gardener. In his review of systems, he had experienced some pretty significant weight loss over the last year, with some progressive fatigue, arthralgias, dysesthesias, and generalized weakness. This is what we saw when we first met, and this, you know, to me, was a kind of a chronically ill appearing guy. His left calf had this large indurated red-brown plaque, and he had several nodules on his right leg, looked kind of like erythema nodosum to me, on his right, but the left, I wasn't sure what that plaque was. Could have been that, could have been a cellulitis, could have been you know, other things as well, some swelling related conditions. But what we didn't, and what he wasn't aware of, is when we were just looking him over the rest of the way, well, he had all these little inflammatory papules. They weren't follicular based, they were just inflammatory papules on his flanks. And they were subtle. We're like, well, how long have you had these? Like, I don't even know that I have them. They don't itch. They don't hurt. There's no symptoms to them. You're pointing them out to me for the first time. But he had about 30 of them. So, you know, at the differential, you know, erythema nodosum or some kind of granulomatous dermatitis were highest on our list. We did the biopsy, and indeed there was a septal paniculitis. But the nature of the septal paniculitis wasn't really classic erythema nodosum. There were some foamy cells, and so we did some special stains and just chuck loaded with atypical or some kind of mycobacteria, right? And this is like a high volume. Like usually when you see it, it's like maybe 1 or 2, or, you know, it's kind of hard to find. This was not hard to find. And so we did not, at the initial stage, we did not do like a whole battery of cultures. We brought the guy back in. We're like, well, geez, you know, this is terrible. You know, and we're like, what kind of water have you been around, and what kind of this and what kind of that? You know, did you ever stab yourself while you were, you know, pitchforking your garden or whatever? Because we've seen all of that lead to atypical mycobacterial infections. No, no, and no, and no. Not that he knows it. And you know that we get the tissue cultures, and they're smoldering, nothing would grow. And I'm getting nervous. I'm talking to my infectious disease consultant. I'm like, look, man, there's a lot of a lot of mycobacteria here. It's getting me a little freaked out. The only time I've ever seen anything like this was in a lepromatous leprosy kind of volume. It should be like be covering you with something. It's like, no, let's wait till we know what we're dealing with, grow the organism. We notified rheumatology, like, hey, you've got this guy on some immunosuppressives for his rheumatoid arthritis. He's got some kind of mycobacteria. We had nothing grew. And so I'm getting really nervous. And so we say, let's rebiopsy and let's send this out for PCR for mycobacteria, the 16S ribosomal analysis. And sure enough, it comes back and it's Mycobacterium lepromatosis. Okay. Well, that's like, holy cow, we are looking at lepromatous leprosy, but the name at the end was a little different to me. You know, Mycobacterium lepromatosis was not familiar to me. I'm used to Mycobacterium leprae. Now, we all know if you've been around dermatology and infections long enough, like these folks like are changing names all the time, right? And so it's like, I think that's part of why they keep meeting is to get together to change names. But this was unfamiliar to me. And in starting to look, it is clearly a different thing. It's similar, but different than M. leprae. So who needs to know? Well, your state health department needs to know. It's reportable in the US. And then the National Hansen Disease Program, who is very, very helpful as another resource for leprosy. And then consulting with infectious disease specialists, always important in these cases. So in just a little bit about lepromatosis, for the last 150 years, M. leprae has been like the thing. But only since 2008 was this second strain, this very, very similar M. lepromatosis identified. And only a handful of cases, 21 known case reports of this lepromatosis. And that's part of why I bring it today, it is weird, but it's also like just to kind of put a flag in your mind about this. M. lepromatosis is considered endemic in Mexico and a few other countries, but is slowly starting to creep into the US. And although it's managed very similarly, this is something to consider. So I got a question for you. What zoonotic source is thought to be a natural reservoir for M. lepromatosis? I'm being a turkey here because this is a tricky question. That's a great answer, and that is true for M. leprae. So it's actually the red squirrel, believe it or not. The 9-banded armadillo is a known vector for the Mycobacterium leprae, but the red squirrel, and I'm going to talk about the armadillo for just a minute. They have actually looked in the armadillo for M. lepromatosis. It's never been found. Okay. So you'd have a case report there if you could find it, but it has been in the UK. It's been seen in red squirrels, in samples of red squirrels. It's been found in Britain and Northern Ireland, but it's not ever been shown that has caused human disease. So what I'm telling you and why I'm bringing this is there is not a known reason why this man has M. lepromatosis. He has no known exposure that we have been able to identify. So that means there may be a vector in our US that's carrying this. So be on the lookout. Okay. And this is my, what's happened to the 9-banded armadillo migration with global warming. And what you can see is it's moved north. I was telling some folks the other day, I grew up in Southwest Missouri. I never saw armadillos in my entire life. Moved to Wisconsin. Now when I go back and visit, there are armadillos roadkill everywhere. And I don't know if that's similarly happening because you guys are in the most recent armadillo mapping. And maybe there's something more recently, but I have 2014. So 10-year-old data, it keeps climbing north with the temperature. So this is the last thing that it's a 2-year therapy. And it works very well. And then this is the standard therapy. What was interesting is the Hansen disease program actually gave us a very specialized therapy, which was unique and different. It was a 1 dose a month triple therapy of minocycline, moxifloxacin, and rifampicin, which was unfamiliar to me. And it has been very effective. It actually led to this guy not needing the ulnar neuropathy surgery because that was leprosy. It also makes the question, what about his rheumatoid arthritis? Because you can get with leprosy, all of the autoantibody profiles can become positive falsely when you have lepromatous leprosy. So that's one of the questions too. Now, as it turns out, the rheumatologists continued their therapy and they're like, even if that's true, you probably need. So anyway, so those are some of the things that I want to just kind of highlight as we close out. So as my last two slides, you've got global example of a lot of emerging diseases, and that's part of what I want to highlight, just be on the lookout, be curious, because new things are going to emerge. And so with that, I don't know that we have a ton of time for questions. I think I've got a few minutes, and I want to thank certainly the opportunity to come and talk to you guys today, but be happy to take any questions that you have. Thank you.
So no red squirrels in Wisconsin is what you're saying?
We do have red squirrels, although it's very interesting. We have more, something that I had never seen until I got there. There's some kind of like melanin mutation or pheomelanin mutation. We have a lot of black squirrels in Wisconsin. We have black and gray, not as many red. We do have red squirrels though, just not as many. He has no history of touching any squirrels. He had traveled at one point. He has been to Ireland, remotely, but that was quite remote. So.
Question for you. You didn't talk about it on this talk, but I was wondering about syphilis, like testing for syphilis. So like a month ago, we saw a patient on consults from Africa, positive PRP, positive VRDL, but it turned out not to be syphilis. And infectious disease was saying it really doesn't matter if it's positive, it's how, is the titers increasing over time? And like a baseline syphilis, which doesn't make sense to have to have a baseline syphilis test.
So that's outside of my knowledge base. I mean, like I'm still coming to grips. I'm still coming to grips with the testing of syphilis because it used to be get the cheap thing that's got the big broad net and it's RPR, and then do your your antibody test second. And now it's like been kind of switched, and I'm still coming to grips with that one. So. I'm not familiar with the getting, the titers over time as your answer. That's a little different than my knowledge. I think our infectious disease guy left.
Hey, well, I want to thank you so much. I'm sure it's really spectacular. Oh, good.